24, and this is our geriatric case competition presentation.
My name is Van Hong. I'm a physician assistant student at Nova Southeastern University in Fort Lauderdale, Florida, and I am our team's care manager.
I'm Matthew Miller. I am a second-year dental student at Missouri School of Dentistry and Oral Health.
My name is Caryn Geiger, and I'm an occupational therapy student at the University of Minnesota.
My name is Ashley Roth, and I am also an occupational therapy student at the University of Minnesota.
Hi, you guys. I'm Hannah Lysne, and I'm a Master's of Social Work student at the University of Minnesota. And our amazing coach was Caryn Geiger, so just wanted to give her a shout out. You can go to the next slide. So Ms. Carolyn Staple is a 79-year-old African-American woman and Vietnam War veteran living in rural Cannon Falls, Minnesota. She shares her home with her husband, Hank, who is also a veteran and her main source of daily care and emotional support. Married for nearly 60 years, the couple was once very active in their church and community. A former teacher and nurse, Carla's independence is heavily shaped by her military and medical background. She lost her leg during the war and has been using a prosthetic leg ever since. She manages chronic pain, fatigue, and limited mobility, which has all really impacted her mental health. And then most recently, an infection at her prosthetic site brought her into our care. For Carla's support system, she's supported by her husband and their 2 adult children, Anthony and Janie, who provide regular care. She also has support from church friends and local neighbors. Carla really strongly values her faith, community, and family. Her medical team includes her primary care provider, rheumatologist, rehab specialist, and our interprofessional care team. Through the VA, she receives disability benefits, medication services, and prosthetic care, along with financial support from her teacher pension and Social Security. Due to frequent flooding and her declining health, she has faced many challenges, though, accessing these services and her support system.
Because of the flood, Carla and her husband lost their home and were relocated to a federal emergency management agency, also known as FEMA, temporary shelter. The living conditions were unsanitary and far from ideal. A few days into her stay, she noticed irritation around the amputation site. With limited medical supplies, Carla used soap and water as she usually would and decided to wait it out. However, over the next 3 days, the redness and irritation worsened, and her pain became unbearable. Carla ended up seeking services at the FEMA mobile clinic, where she ended up waiting over 12 hours at the clinic. Once she was seen, the doctor noted mild redness at the site. Her vitals were within normal range, as noted on the bottom left, and the provider prescribed oral antibiotics. However, due to her lack of transportation, Carla could not pick up her prescription until 2 days later, when her son Anthony was able to do so. This was a common challenge she faced with managing her chronic medications. The next day, Anthony stopped by. He saw Carla in bed with a fever and unable to move due to her pain and forgot Anthony's name. He called 911, and the paramedics identified that she was unstable and required care at a higher level medical facility. EMS transported her emergently to the Minneapolis VA Medical Center for care. Her vitals on arrival were abnormal as shown on the slide, and her wound was now cherry red, extending approximately 3 centimeters above the amputation line with foul-smelling drainage coming from the site. Throughout our time working with Carla, our interprofessional team began to understand not only her medical needs, but also what mattered most to her as a person. During her hospitalization, we sat down together to talk about her recovery, her priorities, and her vision for what came next. I learned of Carla's story, how she cared for her aunt with diabetes as a child, which inspired her to be a nurse. She delivered newspapers as a teen, which helped her develop a sense of independence, and this made her resilient. But it also made it difficult for her to accept help when she needed it most. Carla valued her autonomy deeply, as well as her identity as a nurse, a veteran, and a caregiver. Our long-term plan focused on empowering her, ensuring she could continue to care for herself and maintain control over her daily life, rather than feeling like a burden to her family. In the short term, our primary goal was to control her infection, stabilize her vital signs, and prevent future complications. Carla expressed mouth pain because of a sore spot on her inner cheek. During my physical exam, I observed a single 2-millimeter ulcer I consulted our inpatient dental department, and Dr. Miller evaluated her oral health, particularly as her long-term immunosuppressant use increased her risk for oral infections that could lead to systemic complications. As the lead care manager, I ensured continuity of care by ensuring successful communication between our interdisciplinary team and coordinated services in order to ensure all of Carla's needs were met. In terms of long-term planning, after reviewing Carla's medical chart, I consulted Hannah to initiate conversations about healthcare directives. We also discussed the importance of securing safe housing for her recovery. To support her physical recovery, we placed occupational therapy consults with Ashley and Caryn to address mobility, strength, and safety with transfers, particularly in the context of her prosthesis. Other services we consulted for Carla's care included physical therapy, dietitians, and spiritual care services. For Carla, recovery was not just about getting better, but returning to her baseline level of function. With this in mind, Carla would transfer to a transitional care unit, as known as a TCU, to bridge the gap between inpatient and outpatient care and ensure continuity of care. With Carla and her family's collaboration, our care team used the COVER model to guide her care. We will talk about our experience with this model later in the presentation. Carla's labs were obtained and are listed in the slide below. Based on her presentation and vital signs, Carla met sepsis criteria to her skin infection due to her skin infection that is now circulating in her blood and causing organ dysfunction. Carla received blood cultures, IV antibiotics, and certain medications related to her autoimmune conditions were cut to allow her body to fight this infection. Her chronic medications were continued as clinically appropriate. To ensure the infection did not progress to the joint or bone, I conducted a point-of-care ultrasound, which showed a superficial infection. By the next morning, Carla's wound cultures returned, growing methicillin-sensitive Staphylococcus aureus. The antibiotic coverage was narrowed according to the results. I continued performing repeat point-of-care ultrasounds during Carla's stay to ensure infection did not progress. After each inpatient visit, I called Anthony and Hank and kept them updated. By day 3, Carla's confusion and altered mental status had fully resolved. On the 4th day, her wound continued to improve. Hank and Anthony came to visit her, and they all expressed gratitude for the level of care Carla's received. However, Carla's appetite, mood, and energy were still low, as if something was on her mind. On day 5, I met with Carla to discuss the likelihood of transitioning to a transitional care unit once she was medically stable. Although her infection was improving, she expressed emotional distress about her hospitalization. After understanding her circumstances and her story, we wanted to ensure Carla was well supported. At that point, Hannah became involved in providing emotional and social support and care.
I initially met with Carla on day 4 to complete a comprehensive intake assessment to address her medical, psychological, and social needs. She was initially reserved but cooperative. She expressed a lot of feelings of guilt, saying she felt like she had failed by getting sick again, and she was worried deeply about her family's finances and well-being. Using a trauma-informed, strength-based approach, I validated her experiences as a veteran, a spouse, a mother, and a person managing chronic illness, while also emphasizing her resilience and problem-solving skills. By taking time to build rapport with Carla, she appeared more comfortable and engaged in care planning by the end of our initial meeting. To support her long-term financial and medical stability, I also initiated a VA service connection reevaluation, as her current disability rating was only 40% and it had not been reassessed in several years. Working with her primary care provider, we completed and submitted the necessary documentation through the VA claims portal, and with an increase in her disability rating, payment for hospitalization would work retroactively. Carla and her family were educated on this process, the timeline, and the possible benefits, which included expanded eligibility for home-based care and adaptive equipment. For health insurance, Carla's healthcare coverage is layered. She has Medicare, which covers her primary hospital and outpatient services, while VA healthcare covers most medications, prosthetic care, and her primary care through the VA system. Additionally, Carla and Hank are enrolled with TRICARE for Life, which serves as wraparound coverage. While working with Carla and Hank, I helped them enroll in VA dental insurance program also to cover their dental needs. I coordinated the referral and scheduled for future dental visits for them both. On day 5, after discussing with Carla's PA Van, I returned to facilitate a goals of care discussion with Carla, her team, and our interdisciplinary team to clarify her medical preferences. Carla emphasized her desire for independence, comfort, and to remain at home whenever possible. As Carla's PA Van also asked me to speak with Carla about healthcare directive, we really wanted to make sure we had an active healthcare directive to ensure her wishes were known and respected. I provided education on the document and how to update it if her wishes were to change. She did complete a directive, and the directive was notarized, uploaded to her electronic health record, and shared with her family. At this time, Carla also expressed emotional distress related to being displaced from her home, losing a close friend recently, and coping with her declining health. After offering support, I asked if she would like to meet with a chaplain, and she agreed. So I submitted a consult, and the hospital chaplain met with her that same day to provide that faith-based support. Throughout my work with Carla and her family, I offered systems navigation and connected them with resources to support housing stability, caregiver assistance, and really focus on long-term independence.
Occupational therapy and acute care focuses on restoring functional performance, and one of the first occupations OT would want to address with Carla is her functional mobility. Per chart review, Carla can perform bed mobility independently when her pain is low. However, when her pain is higher, she does require moderate assistance. Here is where I would want to collaborate with physical therapy to determine if Carla would benefit from an ambulatory device such as a cane or a walker. And if so, PT would be the one to fit her to it. OT services would then observe Carla as she completed various occupations to determine her level of assistance. She currently requires moderate assistance with lower body dressing and can perform toilet transfers and hygiene herself, but she does require assistance with clothing management. To determine which occupations are most important to Miss Carla, OT services will utilize the Canadian Occupational Performance Measurement, or COPM, throughout the duration of her therapy services. Another area for interprofessional collaboration would be OT collaborating with dentistry on oral hygiene.
While Miss Carla can complete grooming tasks at a wheelchair level, her grip strength from her rheumatoid arthritis makes her hands difficult to perform proper oral hygiene. So by collaborating with OT, we can help provide her with different items, such as an electric toothbrush to replace the one that she lost in the flood. And there is foam tubing grips that we can add to support her dexterity.
After collaborating with social work, the medical rehabilitation team, and Carla and her family, Carla has agreed to be discharged to a transitional care unit for 30 days. The TCU is where OT and other therapy services can collaborate more closely with Carla. It should be noted that Carla was reluctant at first, but through open, direct communication and clear explanations of the services available at the TCU, she agreed to go.
On day 6, Carla's condition continued to improve. She no longer had any drainage or redness at the wound site, and her pain was controlled successfully with scheduled Tylenol and Advil. By day 8, Carla's wound was clean with healthy tissue present, indicating proper healing. Her vitals were within normal limits, as listed below. And by day 10, Carla had met all medical stability criteria for discharge. Her IV antibiotic course was completed, and she was transitioned to oral antibiotics for 10 days. During the discharge, we discussed medication adherence, wound care, nutrition, and signs of potential reinfection. In terms of measure of success, we discuss maintaining stable vitals, continued oral intake, and progression towards baseline mobility. Carla's health literacy was an aspect that we wanted to promote when it came to her care. She was exuberant and determined to continue managing her health.
After collaborating with the acute care team, I did complete and submit the TCU placement applications and informed Carla, her family, and our team once her acceptance was confirmed. During this time, Hank stayed with her daughter Janie just to ensure that he had the support he may need while Carla was receiving care from the TCU. To maintain that service continuity, I also coordinated with Carla's VA case manager just to provide updates on her medical status, her functional needs, and her discharge plans.
Occupational therapy in the TCU would involve more therapy for longer durations and more frequently while she's here. While being in acute care, she made progress in transfers and mobility. However, we will still continue to address this in the TCU. Again, we will be utilizing the Canadian Occupational measure to determine which occupations Carla would like to focus therapy on. After discussing with Carla and her family, we determined that the occupations we would address include meal preparation, pet care, bathing, laundry, medication management, and leisure participation. Intervention examples may include anything from adaptive equipment such as shower chairs and wide-base utensils or dressing devices. We would explore different leisure activities and ways for her to get involved in the community. There would also be a lot of education on energy conservation, home safety, mobility, coping strategies, and health management. It should be noted that the involvement of Carla's support system throughout this time should be strongly emphasized. The OT education being provided is not just for Carla, but also for her family and caretakers to aid in a safe and positive transition post-TCU release.
Okay, starting with acute care, our main focus is stabilizing Miss Carla and managing any of her immediate discomfort. We can prescribe medication for the pain management, like over-the-counter pain medication, such as ibuprofen and acetaminophen. Relieve pressure areas on her dentures to improve comfort and emphasize the importance of proper oral hygiene. It's also important to support Miss Carla with care that helps relieve any temporomandibular joint issues that she may be contributing to her pain. We can teach her how to do warm compresses, soft diets, and adjusting the partials. As we move into the transitional care unit, the focus shifts to ongoing maintenance and continued care. Here we focus to promote oral and partial hygiene, monitor any of the pain that's and treated as needed, and make sure that the outpatient follow-ups are as scheduled and followed through. If the TMJ function continues, we might collaborate with oral medicine and even physical therapy to provide additional support. Overall, the goal in both settings is to ensure smooth, coordinated care that supports oral health and comfort through every stage of recovery.
After completing her 30-day TCU stay, Carla will likely require monitoring of her prosthetic site, endurance, and safety using home health OT services. The initial focus will be on completing a comprehensive home safety assessment, evaluating ramps, thresholds, bathroom and kitchen access, and identifying any moisture or lighting hazards. From there, OT will help Carla progress in her ADLs and IADLs using adaptive tools such as a shower chair, grab bars, reachers, and a dressing stick. We'll emphasize energy conservation, pacing, and task simplification to manage fatigue and prosthetic pain. A key focus will be reestablishing consistent routines, including safe meal prep, pet care, medication and appointment management, and modified household tasks to reduce fall risk. Because Carla finds meaning in service and connection, we'll also incorporate purposeful roles such as volunteering remotely, attending church, and caring for her dog. Finally, OT will provide caregiver education for both Carla and Hank, covering safe transfers, shared task planning, and strategies to reduce strain while maintaining their independence and teamwork.
To evaluate the effectiveness of our interdisciplinary approach from a medical standpoint, our primary indicators were the absence of rehospitalizations and continued follow-up with wound care. She would continue follow-up and with dry skin management, incorporating compression therapy for her swelling. It was also vital to focus on her chronic health conditions. Her amlodipine was changed to hydrochlorothiazide to reduce the risk of falls, and through the Rochester VA clinic, Carla and her primary medical care team would work on a medication regimen and monitor biological markers for inflammation. To support her long-term bone and metabolic health, Carla would undergo repeat DEXA training every 4 to 8 years. Hannah coordinated with the VA to ensure that Carla had full access to her medication and transportation to future appointments. Additionally, she received a loan tablet for telehealth visits as they did not have regular internet access. This overall reduced barriers and improved the overall continuity of care for Carla and her support system.
Looking ahead, our long-term rehabilitation plan will continue to focus on advancing independence with ADLs and IADLs, ongoing caregiver education, and collaboration with Meals on Wheels to assist with nutrition management as she transitions. OT will also monitor the need for future home modifications such as a stair glide or bathroom remodel through coordination with the VA. As her husband's caregiver, Carla will be supported in finding ways to assist Hank safely while maintaining her own health and balance. We'll continue to help her reconnect with her community, returning to volunteer roles and church involvement as she is able, supporting both her purpose and psychosocial well-being. Alongside OT, PT will focus on endurance, balance, and gait training for prosthetic mobility, while O&P will monitor prosthetic fit and skin integrity. Throughout this transition, our interdisciplinary team will ensure Carla can live safely, meaningfully, and confidently at home again.
During Carla's hospital stay, resource coordination centered on supporting her long-term stability. Carla and Hank decided to stay with their daughter Janie temporarily, but their long-term goal was to use the FEMA home buyout program to sell their flood-damaged property and then purchase a new home with their son Anthony through the VA home loan program. This move will keep them safe from future floods, reduce overall living costs, and keep Carla and Hank in the same community that they love. Ultimately, it will also strengthen their family support, which Carla is excited about. Their son Anthony plans to complete a personal care assistance or PCA training to provide that in-home support for both of his parents while also maintaining an income. The family was connected to the VA Caregiver Support Program, including the Program of Comprehensive Assistance for Family Caregivers, which offers training, respite benefits, and financial stipends. Additionally, the Minnesota Board on Aging Senior Linkage Line was provided for any future caregiver or aging resources they may need. To promote financial stability, Carla and Hank were referred to the Minnesota Veterans Relief Grant Program, which offers emergency financial assistance for veterans. For community reintegration, Carla and Hank plan to reconnect with their local church, a key source of faith and social support for the both of them. Before discharge, we also contacted the American Legion Post 142 in Cannon Falls, where they plan to join for that peer connection. This coordinated plan addresses both medical and psychosocial needs while honoring Carla's independence, values of independence, family unity, and community connection. While not all services are needed immediately, proactive education has equipped the family with tools and resources to ensure a safe transition and long-term stability.
Our team used the COW model developed by Michael Iwama as the framework to represent Carla's overall life flow and the many factors influencing her recovery. During a meeting with Carla, her family, and her care team, we walked through each step of the COW model to identify Carla's strengths, challenges, and supports to develop meaningful solutions. The water represents her life flow, which has been disrupted by her infection, the flood, and major changes in her daily routines. The rocks are the main barrier she's facing: her pain, limited mobility, being away from her home, emotional stress, and loss of independence. Her driftwood includes her resilience, faith, sense of humor, strong family support, and her nursing background. The riverbanks reflect her environment, including VA resources, community sports, and her temporary accessible housing. The COW model guided our work by helping us see which barriers needed attention first and which strengths we could build on. It also helped us understand how each discipline could support different parts of her river. Social work supported housing stability and caregiver resources. The physician assistant managed her medical needs and infection. Occupational therapy focused on function, routines, and safety, and dental addressed the oral health as part of her overall well-being. Using this model helped our team stay coordinated and create a plan that supports Carla's life flowing forward with safety, purpose, and connection.
Overall, we spent a total of 8 hours collaborating on Zoom as a team for the regional competition, along with many hours of independent work. From November 7th, when the regional winners were announced, till this presentation, we have spent an additional 6 hours collaborating on Zoom. Overall, each member of this team can confidently say this is one of the best interprofessional experiences we have had.
As for our interprofessional collaboration improvements, we as a team, our biggest thing that we think we can improve on would be defining roles and expertise for each professional and outlining who handles what to avoid gaps in the care.
And these are our
reference.
And that concludes the presentation.